Hi everyone, and in this video I'll be discussing anti-epileptic drugs. To understand the anti-epileptic drugs, you need to understand what is seizure, what is convulsion, and what is epilepsy. Now, seizure is a brain electrical activity. So, patient will have some triggering factor, and he will have the convulsions which you can see. There are so many reasons for seizures: a trauma, tumor, infection. Drugs can cause seizures. Epilepsy is a condition where the seizures recur again and again without any stimulus, unprovoked. And the problem here is the CNS is hyperexcited. That means CNS is excited, it is trying to fire. And when it fires, the all other body parts have the seizures. Now what we should do? We should do one thing, suppress the CNS and block the conduction from CNS to the periphery. And that is how most of the anti-epileptic drugs work. So let me clarify certain things for you. Seizures. So seizure is an electrical activity that is stimulating the brain to fire continuously. Then convulsions are the one which you see because of seizures. So what you see, the generalized tonic-clonic seizure, what a patient is doing, that is what we see. What is epilepsy? Epilepsy is when the patient has more than or equal to 2 episodes of unprovoked seizures. That is epilepsy. So whatever the condition, remember seizures are the electrical activity, the CN is excited and you cannot see it. Convulsion is what you see. But many a times we use this term interchangeably. Now what is the triggering factor for seizures? The triggering factor may be due to a tumor. Patient would have sustained a trauma to the head trauma. Or there may be CNS infection like meningitis. They can also cause seizure. And the drugs. Can you give an example of a drug which causes seizures? Imipenem, high doses can cause seizures. INH, overdose can cause seizures. So, there is a triggering factor for seizures, but unprovoked seizures, if they recur more than two or more than two, we call it as epilepsy. Now, whatever it is, we need to suppress the brain. The brain is hyperactive. Now, what are the drugs going to target? We have already discussed something in sedative hypnotic, how to depress the brain. We have the excitatory neurotransmitter and inhibitory neurotransmitter. The excitatory neurotransmitter is glutamate and the inhibitory neurotransmitter is GABA. So it's a hyperactive CNS condition. So we need to suppress it. How do I do that? Either I should decrease the activity of glutamate or I should increase the activity of GABA. That is what we can do. Second, who will take the impulse from the brain to the periphery so fast? It is nothing but the sodium ion. So we can block the sodium ions and that will also help. And there is one more ion in the brain, that is T type of calcium channels. Now these T type of calcium channels are problematic in particularly absence seizures. A potassium channel is also going to play a role in management of seizures. So there are totally 5 targets in the management of seizures. Number 1, block the sodium channel. Number 2, we can do like this. Number 2, increase the activity of GABA. Number 3, decrease the glutamate activity. Number 4, block the T type of calcium channels. Number 5, you open the potassium channel. So number 5, open the potassium channel and make the cell depressed. So these are the 5 targets to manage seizures or epilepsy. Block the sodium, increase the GABA activity, decrease the glutamate because it's excitatory, then close the T-type of calcium channel that are defective in absent seizure, open the potassium channel. You know, when you open the potassium goes out to the cell and the cell will become more negative and gets depressed. And you all know that which is the ion which carries the impulse from the brain to periphery so fast is sodium. Block it. So with that introduction, let us start our journey. And what are the drugs? Anti-epileptic drugs. Number one, the drugs are called sodium channel blockers. So they are sodium channel blockers. Now what are the drugs we have? In that we have the major drug phenytoin. Very, very important drug, phenytoin. Then we have carbamazepine. Then we have sodium valproate. Sodium valproate. Then lamotrigine. Lamotrigine. Then a drug by the name topiramate. So these 5 drugs are very, very important for the exam point of view, and they will ask you in and out about these drugs. And we'll discuss them in detail. The other sodium channel blockers are zonisamide, then a drug by the name rufinamide, and a drug by the name felbamate, and a drug by the name lacosamide. So mainly you need to concentrate on phenytoin, carbamazepine, sodium valproate, lamotrigine, and topiramate. So by blocking the sodium channel, they decrease the impulses coming from the brain to the periphery. So they block sodium channel. We'll discuss one by one. The first one is phenytoin. Now when you think of phenytoin, try to correlate in general pharma. Pharmacokinetically, phenytoin is what? It's an enzyme inducer. That means it can increase the enzyme synthesis, and drug interactions are a problem with that. Second, phenytoin follows a kinetics called saturation kinetics. And I told you most of the anti-epileptics require therapeutic drug monitoring, and the normal level is between 10 to 20 microgram per ml. This is the normal level. Now if the drug is less than that, it will not work. More than that, it will cause toxicity, that is phenytoin. Now phenytoin pharmacokinetically, when you give it intravenous, phenytoin has to be mixed with, you have to mix it with normal saline. So when you are giving IV, you should mix it with normal saline. You should not mix it with, don't mix with dextrose. If you mix with dextrose, it can get precipitated. Never mix it. Now very, very important, when you give the drug IV, rarely it can produce a problem called purple glow syndrome. So it can produce, when we give IV, because of venous irritation, it can cause, very rare, it's not a common problem, purple glow syndrome. Now don't push rapidly. If you give rapid IV, it can cause arrhythmias. So when you are using it, it's very important you do the ECG monitoring. Very, very important. Why it can cause arrhythmia? It is also, phenytoin belongs to which class? It is a class 1B antiarrhythmic. And you know that antiarrhythmic, if you increase the dose, they themselves can cause arrhythmia. So very much important. It's an enzyme inducer, follows saturation kinetics, require therapeutic drug monitoring, IV when you are giving, very very important. You can mix it with normal saline. Don't mix with dextrose. Now to prevent this venous irritation, there is a drug called fosphenytoin. Fosphenytoin is more water soluble and less irritation to the vein. Fosphenytoin after metabolism is converted into phenytoin. Is it an example of prodrug? Absolutely yes. It is a prodrug. And nowadays in emergencies, when we have to give IV phenytoin, what we prefer is fosphenytoin because of less venous irritation. And one more advantage, you can mix with both normal saline as well as dextrose during administration. Very, very important. So once I understood the pharmacokinetics of phenytoin, let us understand where to use it. It is mainly used in generalized tonic-clonic seizure. It is used in status epilepticus. And it was also tried in trigeminal neuralgia. In trigeminal neuralgia, it is a second line drug. It's a second line drug. And phenytoin belongs to class 1B antiarrhythmic. Class 1B antiarrhythmic action. So why should I know it belongs to class 1B antiarrhythmic? Suppose patient is given lignocaine and it's a class 1B antiarrhythmic, and patient had lignocaine toxicity and had seizures. So when lignocaine is given, patient may have CNS excitation seizure. That time don't use phenytoin to control the seizure because phenytoin and lignocaine have same mechanism on the heart and that can lead to arrhythmia. So lignocaine induced seizures, don't use phenytoin. Now which epilepsy we should not use this drug, phenytoin? Phenytoin is contraindicated in myoclonic as well as absence seizures. The reason is it has shown to increase their seizures when it is being used. That's the point. So don't use it in myoclonic as well as absence seizure. Very, very important point. Another important aspect when we think of phenytoin is its adverse effect. Remember, all the adverse effects of phenytoin start with the letter H. So it can produce hypersensitivity. Nothing but allergy. So hypersensitivity can be presenting as Stevens-Johnson syndrome, or the patient may develop lymph node enlargement. Patient may have lymph node enlargement, and lymph node enlargement looks like lymphoma. So we call it as pseudo lymphoma. Now why it is called pseudo lymphoma? Because the lymph node enlargement is not because of cancer lymphoma, it is because of the drug hypersensitivity. One more H is hyperplasia of gums. So it will cause hyperplasia of gums. Gums will become hyperplastic, that is big in size, or we call it as gum hypertrophy. Now it can also cause hirsutism. So a female patient may not accept this for longer therapy because of the problem hirsutism. And it can cause hyperglycemia. The glucose level may rise. Now if you use the drug at high dose, it can cause cerebellar problem, that is cerebellar ataxia, and it can cause nystagmus. And high dose, when you push IV, I told you it can also lead to arrhythmias. So whenever you think of phenytoin, remember what are the highs? Hypersensitivity, hyperplasia of gums, high AIRS, more AIRS, hirsutism, high glucose and high dose. Another important is, can we use it in pregnant women? It causes hydantoin fetal syndrome. So not used in pregnancy. Remember, it is also called as fetal hydantoin syndrome. The problem here is the child will have cleft lip and palate. That is one feature. Second, the fingers are very small. Small digits, we can write it as small digits, also called as microdactyly. Then cardiovascular defects. So these are mainly seen in fetal hydantoin syndrome. Now when we start phenytoin to someone, it causes 3 hypo. Hypo. 3 will become less. What are these? There are 3 vitamins. 3 vitamins will become hypo. What are those? Let me tell you that. Number 1, what is the vitamin? It decreases the vitamin D levels, and that will lead to a problem called osteomalacia. So osteomalacia can happen when the vitamin D decreases. One more vitamin it decreases is vitamin K. Now, when the vitamin K decreases, that will also contribute for osteomalacia. So patient on phenytoin therapy, if he develops osteomalacia, you have to give vitamin D plus vitamin K. One more reason why osteomalacia can also develop is when we use phenytoin, it also produces hypocalcemia. So one more hypo is hypocalcemia. Now when the vitamin K is decreased, suppose we give phenytoin in pregnant women. I told you pregnant women we should not give it, but there are certain conditions where we use it. I will tell you in the end of the video. When I use this in a pregnant woman, it can decrease vitamin K. So it can lead to hemorrhagic disease of newborn. Hemorrhagic disease of newborn. Now tell me how to avoid that. So if pregnant woman on phenytoin, the baby born will have this hemorrhage. So what we do is, to the mother, when she is at the term, we give vitamin K oral. For the newborn, what we do is we give vitamin K injection. We give vitamin K injection to avoid this problem. Another important problem is when we use phenytoin, it decreases folic acid. And you know that folic acid deficiency can lead to which anemia? Yes, megaloblastic anemia. So these are the long-term problems what we see with phenytoin, and please understand all the adverse effect starts with H. That's why I made sure that in the beginning all are hypersensitivity, hyperplasia of the gums, hirsutism, hyperglycemia and high doses. The long-term complications are the teratogenic risk. There are 3 hypos, vitamins, vitamin D, vitamin K and folic acid, and hypocalcemia. So these are the important points you need to keep for phenytoin, very, very important drug. The second drug in sodium channel blocker is carbamazepine. Carbamazepine. Please don't confuse with chlorpromazine. It's an antipsychotic drug. This is an anti-epileptic drug, carbamazepine. For carbamazepine, pharmacokinetically, it's an enzyme inducer. Second important point is it's an auto-inducer. You know from general pharma, inducer means a drug which increases enzyme synthesis. Autoinducer means it induces the enzyme so that the enzyme metabolize the carbamazepine itself. So the carbamazepine becomes shorter acting. Another important, it requires therapeutic drug monitoring. It should be between 5 to 10 microgram per ml. So this is the normal level. Sir, what do you understand by autoinducer? For example, I have put a patient on carbamazepine for a particular type of seizures. Okay, I have put. And after 1 month, patient is on controlled, there is no seizures. After 3 months, patient will again come with telling that, sir, I had 2 episodes of seizures. Now, question asked is, will you decrease the dose, increase the dose, keep it same, or change to other drugs? Yeah, take your chance. Now, when I start carbamazepine, it was working, the seizures were controlled. But when I using for very long time, carbamazepine is going to cause enzyme induction and that will metabolize carbamazepine. Now carbamazepine cannot control the seizures. So what should I do? I have to increase the dose of carbamazepine in this patient. So that is the meaning of auto-inducer. Clear? Yes. So once I know the pharmacokinetics, let me tell you the uses of carbamazepine. Where do you use it? Now in epilepsy, it is used in generalized tonic-clonic seizure. It is the drug of choice for focal or partial seizures. The other non-epileptic uses, it is used in bipolar disorder. It is used in management of mania. And it's a drug of choice for one neurological condition. What is that? Neuropathic condition. It is called trigeminal neuralgia. Very, very important point. It's a drug of choice for a neuropathic pain, that is trigeminal neuralgia. Now please understand, it is also contraindicated in 2 important seizures, myoclonic as well as absence seizure. Don't use carbamazepine, it can increase them. What is the adverse effect of carbamazepine? Carbamazepine can cause this adverse effect. You can remember it as HAT, H for hepatotoxic. The drug is hepatotoxic. Number 2, it causes hyponatremia. So the hyponatremia is called as dilutional hyponatremia. What is it called? Dilutional hyponatremia. So A for drug produces allergy. So patient with allergy can present with Stevens-Johnson syndrome. So patient may have Stevens-Johnson syndrome. And T for the drug can produce teratogenicity. So what is the teratogenic effect? What we see is the NTD. NTD stands for the neural tube defects. Along with that, it can produce cleft lip and palate. And one more important T it will produce is thrombocytopenia. So these are the problem what we face with carbamazepine. HAT, hepatotoxicity, hyponatremia, allergy, and teratogenicity and thrombocytopenia. So similar to this carbamazepine, we have 2 more drugs, and that is called oxcarbazepine, and one more is called acylcarbazepine. Now what is their specialty? These are prodrugs. So after metabolism, they will become active. Don't think that they will become active to carbamazepine. They will become active metabolite, something else, not carbamazepine. So they will form an active metabolite. but not carbamazepine. So prodrugs, and they are used for focal seizures. And what is the difference between this and carbamazepine? What is the difference? They have less enzyme induction. So the drug interactions are minimal with them. Then less hepatotoxic, less allergy. They produce less allergy and less thrombocytopenia. But one problem is more dilutional hyponatremia. So they can ask in the exam what is the difference between the two. So enzyme induction is lesser, so drug interactions are also less. Hepatotoxicity is less, allergic reaction, thrombocytopenia, but what is more is only dilutional hyponatremia. Apart from that, they are better compared to carbamazepine because of these advantages, pharmacokinetic advantages. So that is about the drug carbamazepine and related drugs oxcarbazepine and acylcarbazepine. The third sodium channel blocker what we are going to discuss, very much important, it is called as sodium valproate. It is called sodium valproate, also called as valproic acid. Talking about pharmacokinetics, remember most of the anti-epileptics what I discussed is enzyme inducers. So this is an enzyme inhibitor. This is enzyme inhibitor. Mechanism of action is multiple mechanisms. So it's a sodium channel blocker. It increases the activity of GABA. It decreases the activity of glutamate. And it's a T type of calcium channel blocker. So you name all the four mechanisms are present with sodium valproate. It's like a broad spectrum anti-epileptic. So with that broad spectrum of anti-epileptic activity, where to use it? Uses. So let me classify that as epileptic and non-epileptic uses. So epilepsy, where to use it? And non-epileptic uses. Clear? So epileptic uses, it is used in GTCS, generalized tonic-clonic seizure. It is used in myoclonic seizure. It is used in myoclonic absence, right? So it is also used in a syndrome called Lennox-Gastaut syndrome and Dravet syndrome. So for all these, it is a drug of choice. Valproate is the drug of choice. Valproate is also used in one more condition, that is juvenile myoclonic epilepsy. So it is used as drug of choice for GTCS, myoclonic absence seizure. Then it is used in Dravet syndrome, Lennox-Gastaut, and also drug of choice for juvenile myoclonic epilepsy. You may ask a question, do we use it in status epilepticus? Yes, it is also used in status epilepticus. We give that IV, but not a drug of choice. What about non-epileptic uses? It is used in mania. It is used in bipolar disorder. And also it's the drug of choice for rapid cyclers. So rapid cyclers in bipolar disorder, it's the drug of choice. It is also used in a prophylaxis, that is migraine prophylaxis. Very beautiful drug for migraine prophylaxis. And it is also used in certain cases of tardive dyskinesia. So you should know the drug valproate. It's an enzyme inhibitor, multiple mechanism of action, and that's the reason the uses are also so much. So once you know all this pharmacokinetics, mechanism of action uses, let us understand the adverse effect. Very, very important, the adverse effect. So what are the adverse effect of valproate? You can remember by the name valproate itself. Let me write. So it produces vomiting and nausea. Now that is the most common adverse effect what we see with valproate. Your favorite also, GAT upset. A for alopecia. So the drug will cause loss of hair. Compare that with phenytoin, which causes gain of hair, that is hirsutism. Then L for the drug produces liver toxicity. Now can you tell me, can we combine valproate and carbamazepine together? Yes or no? No. The reason is both are hepatotoxic drugs, and the risk of hepatotoxicity increases. P for the drug can produce pancreatitis, and it can increase PCOD. Then R for the drug produces rash. O for obesity. A, the drug will produce ammonia. What ammonia? It will increase the ammonia level. So what we call it as valproate induced hyperammonemia. So what is the antidote for that? To decrease this, the antidote is called carnitine. The antidote is carnitine. Next, the drug can produce teratogenicity. So teratogenicity, what we see with valproate is mainly neural tube defects. Remember, the teratogenic risk is very high with valproate, most teratogenic drug. Now, how do you prevent this? To prevent neural tube defect, a patient on valproate, we use folic acid. How much should be the folic acid? It is around 4000 microgram per day, and that is what we use to prevent that. Second important problem what we see is it can also produce thrombocytopenia. And it's an anti-epileptic drug. Obviously, it requires therapeutic drug monitoring, and the level should be between 40 to 100 microgram per ml. And the last one is E. It's an enzyme inhibitor. So all the points of valproate are there in the name itself. Adverse effects: vomiting, nausea, alopecia, liver toxicity, pancreatitis, PCOD, rash, obesity, and hyperammonemia can be managed with carnitine, teratogenicity, thrombocytopenia, and requires TDM and the enzyme inhibitor. So please remember, these three drugs are very, very important for your exam point of view. That is phenytoin, carbamazepine, and valproate. So let us move on to the fourth drug. And the fourth drug is called lamotrigine. The fourth drug is lamotrigine. Lamotrigine is basically a sodium channel blocker. It is known to decrease the activity of glutamate, which is an excitatory neurotransmitter. Now, coming to lamotrigine, where to use it? It is used in generalized tonic-clonic seizure, then myoclonic seizure. It is also used in absence seizures. But one drawback of the drug is it can cause Stevens-Johnson syndrome. That is a major problem. Major problem is Stevens-Johnson syndrome. Do we use lamotrigine in status epilepticus? No, we don't use it. Do we use it in acute mania? No. So it is used in bipolar disorder also, but not used in mania and status epilepticus. Very much important. Please write down that. Lamotrigine is not used in status epilepticus and not used in acute mania, because in these cases you have to give it IV, and when you give IV there is a risk of Stevens-Johnson syndrome. So that is the fourth drug, lamotrigine. In the future it may replace valproate. Let us see. Now the fifth drug is a beautiful drug by the name topiramate. The name is topiramate. Very, very important. As you know, it's a sodium channel blocker. Not only that, it is a carbonic anhydrase inhibitor. Remember, the carbonic anhydrase inhibition property can cause calcium stones in the kidney. So the drug can produce calcium stones. And another important, it has AMPA antagonism. You know, AMPA is a type of glutamate receptor and it can block that also. The name is topiramate. So it's a sodium channel blocker. It has a carbonic anhydrase inhibiting property and also has AMPA antagonism. Where do I use this drug? The drug has other utility to decrease craving in alcoholics. Very good. It is used in management of obesity. It is also used in the management of migraine prophylaxis. Not for attack, but for prophylaxis of migraine. And it is used in epilepsy. That is what we are discussing. In epilepsy, mainly it is used in GTCS and LGS. LGS means Lennox-Gastaut syndrome. So that is about the drug topiramate. Now, what are the anti-epileptic drugs which can cause the calcium stones or renal stones? What anti-epileptic drugs can cause renal stones? You can remember a mnemonic, topaz. Topaz is a stone. So topa means topiramate. Z stands for another drug, zonisamide. That means zonisamide also has carbonic anhydrase inhibitor property. So that is topiramate, very, very important drugs. So you have to remember these drugs mainly. Apart from that, we have rufinamide. Apart from that, some minor drugs I'll write. Rufinamide, it's a new drug that is used in managing Lennox-Gastaut syndrome. The other drugs are felbamate, zonisamide, and lacosamide. So felbamate and zonisamide, they can cause weight loss. So what is another drug which can cause weight loss is topiramate. So in anti-epileptic therapies, the drugs which cause weight loss are felbamate, zonisamide as well as topiramate. All these three drugs can cause weight loss. So this is about the drugs which block sodium channel, and you have to keep them in your mind. Moving on to the second important aspect, what are we going to do is to increase the activity of GABA. Increase the activity of GABA, which is an inhibitor neurotransmitter. What to do now? What we can do is we can increase the GABA activity. So this is the synapse, the presynaptic terminal and the postsynaptic terminal. Now glutamate will give rise to GABA, and the enzyme is called glutamic acid decarboxylase. Now this GABA is stored in the vesicle, and whenever the signal comes, when the sodium enters, calcium enters, this will fuse and there is release of GABA. So you know the neurotransmission. Now this GABA acts on the receptors. They are called GABA A, and you know that GABA A are ion channel receptor. So it will act on this GABA A. And this GABA is metabolized by an enzyme called GABA transaminase. It is metabolized by GABA transaminase, or it is taken up back by a transporter called GABA transporter. Now what I want you all to do is pause this video and try to analyze how do we increase the activity of GABA here. What are the drug targets we have? Yes. Number one, what we can do is inhibit this GABA transporter so that GABA activity increases. So the name is tiagabine. So it is called tiagabine. You can read the name, transporter inhibitor of GABA. It is tiagabine. It is mainly used to manage PS. PS means partial seizures. Now you can inhibit GABA transaminase, and the inhibitor is called vigabatrin. You read the name again, GABA, TR for transaminase, IN for inhibitor. Now where to use it? It is used in infantile spasm. A patient with infantile spasm with tuberous sclerosis. So if the patient has infantile spasm and tuberous sclerosis, then we use vigabatrin. The problem with vigabatrin adverse effect, remember VI for it can cause vision impairment. So it can cause vision impairment. What is it? It can decrease the visual acuity. And since it's an infant, it cannot complain the vision disturbance. So that's why we avoid it. Even though we know it's a beautiful drug for infantile spasm, we don't use it. Only if there is tuberous sclerosis along with that, then only we use the drug. The name is vigabatrin and everything is in the name. VI for vision impairment, GABA means the GABA transaminase inhibitor. Anything else we have? Now another thing is you can use a drug which can increase the activity of GABA, which you have already studied in sedative hypnotics. What is it? They are nothing but barbiturates. So barbiturates which are used in the management of epilepsy, the drug is called phenobarbital. So phenobarbital can be used in the management of generalized tonic-clonic seizure as well as status epilepticus. One more drug is primidone. It is also used in the management of GTCS. And remember, primidone after metabolism will give rise to phenobarbital. It's an example of active drug, primidone, giving rise to active metabolite, phenobarbital. And both are available as separate drugs. Then we have the benzodiazepines. So the benzodiazepines that are used are lorazepam, diazepam. Usually these two drugs are used for emergency management of status epilepticus, then midazolam, then clonazepam, clobazam. So these are the drugs which are used in the management of epilepsy, and lorazepam is a drug of choice for status epilepticus. So these are the drugs which play a major role in the management of epilepsy by increasing the activity of GABA. So we're done with second target. So the third important target, what we are going to do is decrease the activity of glutamate. So let us decrease the activity of glutamate. And we know glutamate is an excitatory neurotransmitter. How to do that? Let us write the synapse here. Let us write the synapse. Yeah. So glutamate is an excitatory neurotransmitter, and this is stored in a vesicle. This is the vesicle in which glutamate is stored, and whenever there is entry of sodium, there is entry of calcium, and that will fuse the membrane and there is release of glutamate. And glutamate is an ion channel receptor, and it has three subtypes: the NMDA, then one more AMPA, and one more kainate. So these are the subtypes of receptors, and they allow the entry of either sodium or calcium, which are positive, which can excite the tissue. Now when the tissue is excited, there will be seizures. Now you have this image in front of you. Tell me where it should be blocked. So number one, we can do one thing: block the calcium entry. So this is called N-type calcium, meaning is neuronal type of calcium, and that is blocked by N-type calcium channel blocker, and they are called pregabalin. And one more drug is gabapentin. Previously, they were thought to work on the activity of GABA. Now the theory has changed. They decrease the glutamate activity. Now these two drugs are approved for two conditions. One is diabetic neuropathic pains. So diabetic patients will have neuropathic pain, there we use it. And one more condition is post herpetic neuralgia. So these are the uses of pregabalin and gabapentin. Now one update: gabapentin and pregabalin, not both. Only gabapentin is nowadays the drug of choice for a condition called restless leg syndrome. So restless leg syndrome. Since they both decrease the activity of glutamate, they can cause sedation as adverse effect. Then we have a SV2A protein which will try to stimulate the release of glutamate, CRMP2 protein which is also trying to stimulate the release. So it is also trying to release. Now we have a drug which can inhibit this, and the name is called lacosamide. So lacosamide is a drug which inhibits CRMP2. Not only that, lacosamide also is a sodium channel blocker. We have discussed that already. One more additional mechanism of action is it inhibits CRMP2 and thereby it inhibits glutamate release. You can also inhibit the SV2A protein. So SV2A blockers are levetiracetam. So levetiracetam, many times you will confuse lacosamide and levetiracetam. Remember, leve V for vesicle, SV2A. So SV stands for synaptic vesicle 2. So the name is levetiracetam, and one more drug is brivaracetam. So these two drugs inhibit SV2A. Is there any other way we can decrease the activity of glutamate? Yes, you can block NMDA. So NMDA can be blocked by an anti-epileptic drug, felbamate. I think we have studied felbamate already. So felbamate has additional property to block NMDA. It's a sodium channel blocker, also blocks NMDA. You can block AMPA, and that is done by topiramate. So topiramate can block AMPA. So still we don't have any target drugs for kainate. Now moving on to another AMP antagonist. What are the other AMP antagonists we know of? The other AMP antagonists we know of are param panel, and one more is telem panel. You read their name, they have AMP in their name, AMP, AMP, and they are used for the partial seizures. So AMP antagonist. So just analyze this, and when you revise this image should come to your mind. So the calcium channels are blocked by pregabalin and gabapentin. Then CRMP2 is inhibited by lacosamide. SV2A protein is blocked by levetiracetam, brivaracetam, and NMD antagonist is felbamate, AMP is topiramate, and two new drugs, perampanel and terampanel. And there is still discovery for kinate. Okay, so moving on to the next target, the fourth one. The fourth one is to block T type of calcium channel. So the name is called ethosuximide. So ethosuximide is mainly used in a condition called absence seizure. So ethosuximide is used in absence seizure. The fifth target is potassium channel openers. We know that when you open the potassium channel, the potassium positive ion goes out and the cell becomes depressed. So we have a drug by the name ezogabine. Ezogabine is also called by another name, retigabine. And these drugs are approved for management of which seizure? Partial seizures. Now moving on to the adverse effect, these drugs can cause retinal toxicity. So the question asked is, when you start these drugs, what monitoring you want to do? Routine eye examination should be done. Routine eye examination should be done. Second problem is they cause blue pigmentation. They cause blue pigmentation of structures such as skin, nail, as well as lips. So that is the problem with ezogabine or retigabine. Now one application I'll ask you. Suppose a patient is on retigabine for the condition called partial seizures. So patient is taking for that. But with that also it is not getting controlled, and the doctor want to add phenytoin to control the partial seizures. To control that, they want to add phenytoin. Now you have to tell me, when phenytoin is added, what should be the retigabine dosage? What should be the dose of retigabine, normal, increased or decreased? So pause this video and tell me the answer. Yeah, phenytoin is an enzyme inducer. Now what happens when I add phenytoin with retigabine? It will be metabolized faster. So the duration of action decreases. So what should I do? To avoid that problem, when I add retigabine and phenytoin, what should I do? I should increase the dose of retigabine. So these are the application exercises which they can ask in the exams. Increase the dose of retigabine. So until now what I discussed are the targets and the drugs, their specialties. Particularly if you see that we concentrated mainly on the sodium channel blockers, that too on first 5 drugs. So once you know the mechanism, their major adverse effect and uses, it is important that we know the seizures and what are the drug of choice for that. Let us go to that. Let me write the types of seizures. Okay, so let me write them. So number 1, the generalized tonic-clonic seizure, myoclonic seizure, or juvenile myoclonic epilepsy. For all this, the drug of choice is valproate. The drug of choice is valproate. Many a times, absence seizure, student keeps on asking the question. Absence seizure, there may be atypical cases. If there are atypical absence seizure, the drug of choice will be valproate. If it is typical absence seizure, if it occurs in childhood, typical absence seizure in childhood, then the drug of choice is ethosuximide. So childhood typical, it is ethosuximide. Atypical, whatever the age, it is valproate. What are the other drugs we use for absence seizures? So drug number 1 valproate, drug number 2 ethosuximide. What are the other options we have that can be asked in the exam? The other options for absence seizures are lamotrigine, acetazolamide, then zonisamide, and a benzodiazepine called clonazepam. A benzodiazepine called clonazepam. These are the options what we have. But remember, if it is atypical, the drug of choice is valproate. Childhood absence, typical, it is ethosuximide. Then once we understood GTCS, myoclonic, juvenile myoclonic, and absence seizures, what about the partial or focal seizures? Partial or focal seizures. So the first choice of drug is carbamazepine. Right. Moving on to the other types of seizures. Let me extend this. Moving on to other types of seizures. What are the other types of seizures I should know of? The febrile seizures. Now febrile seizures occurs during high grade fever, particularly in children's. Now what happens in a home, they should administer it. Sometimes what we give them is intranasal midazolam because it's easy to administer at home. The older practice is to give rectal diazepam. So in the hospital, if you have IVSS, if you have IV access, then you can give either lorazepam or diazepam. So if the IVSS is not there, then you have to go for midazolam or rectal diazepam that can be given. The next important aspect is a condition called infantile spasm. So infantile spasm is also called as West syndrome or Hips rhythmia. What is the drug of choice for this? The drug of choice is ACTH. The drug of choice is ACTH. Suppose the child has infantile spasm plus tuberous sclerosis. Can you tell me what is the answer for that? It is vigabatrin. Now there are childhood epilepsy syndrome, that is Lennox-Gastaut syndrome and Dravet syndrome. For that, the drug of choice is valproate. Valproate. And coming to eclampsia, which occurs during pregnancy, what is the drug of choice? You all know it is magnesium sulfate. Magnesium sulfate is a drug of choice for eclampsia. One more problem is status epilepticus, which is asked. What do you mean by status epilepticus? It's a condition where the seizure will continue for more than 30 minutes. Even it may stop in between, but it will continue more than 30 minutes. It's an emergency. You have to manage in hospital. So in managing status epilepticus, the drug of choice is IV lorazepam. That is the first choice. Or if you don't get lorazepam, you can start diazepam. So if both are there, go for lorazepam. Still the patient is having seizures, then you have to change the medication, then you have to add phenytoin or forced phenytoin can be added. Still the convulsions are not subsiding, then you have to add phenobarbital. Still the patient is convulsing, then the last resort is general anesthesia. It is given with either midazolam or propofol. So this is the usual protocol what is used for managing status epilepticus. Now what are the other options we have? Other options to manage status epilepticus if it is not controlled. What are the other anti-epileptics which we can give IV? Are the valproate. Then we have levetiracetam. And certain hospitals also uses thiopentone sodium. And obviously they should be given intravenous for managing status epilepticus. So at this slide, you are in a position to understand the different types of epilepsy and what are the drugs used in the management of this epilepsy as the drug of choices. And we have compiled that in one slide. Now moving on to some applied aspect. The applied aspect is, okay, some of the important applied aspect. What about the use of anti-epileptic in pregnancy? Now let me explain that with the two cases, case 1 and case 2. Now case 1, the woman is married and she has epilepsy and she is on anti-epileptic therapy, that is valproate. So she has generalized tonic-clonic seizure and she is taking valproate. Now she becomes pregnant and she comes to your clinic. What will you do? Second patient, she is also married. She is also on valproate for generalized tonic-clonic epilepsy. And she has come to you and she tells that she is planning for pregnancy. She is planning for pregnancy. Okay, so you pause the video and try to analyze how will you manage these cases. Yeah. Now case 1, she is married and she is already on valproate and now she has become pregnant. So in this case, what is your further next step? Should we stop valproate or should we replace with lamotrigine or levetiracetam? What should we do? Now since she is already on valproate, don't stop valproate, because when you stop an anti-epileptic drug, the seizures can occur again and it will not also affect the mother, it will also affect the growing fetus. So here, continue valproate. The reason is, if I tell valproate causes teratogenicity, if I give to 100 women, remember not all the 100 will have that teratogenic effect, 10 or 15 will have that. So we have to take a chance here. So when I give valproate, continue the valproate and you have to add folic acid to prevent neural tube defect. Add folic acid, how much? 4000 microgram per day. Along with that, we have to check for anomalies. If there is gross anomaly, then we can abort it. Otherwise, you can continue the pregnancy with valproate only. Second case, she is on valproate and she has come to you, sir, we want to plan for pregnancy. What step can be taken? Now, in this case, you can change from valproate to some safer one. So you can plan. So from valproate, you can shift a patient to safer one. What are the safer anti-epileptic in pregnancy? Remember L and L. L for levetiracetam and L for lamotrigine. If both are given, which is more safer? Levetiracetam is more safer. Now what we do is, today patient is taking valproate, tomorrow I will not shift a patient levetiracetam. Gradually reduce the dose of valproate and gradually I add levetiracetam, and this is how I shift a patient. Now with levetiracetam or lamotrigine, patient has no seizures, then we tell the patient to become pregnant. So then she can plan for pregnancy. So when we shift the patient from valproate to levetiracetam or lamotrigine, we check for 2-3 months whether seizures are controlled. When they are controlled, then we tell them to plan for pregnancy, let her become pregnant. So these are safe in pregnancy, it's no problem. Remember L and L, levetiracetam and lamotrigine. So this is how we manage the cases in pregnancy. Many times people will not come and tell us they are on anti-epileptic therapy, they will become pregnant, then they will come. Now, another application is when to stop anti-epileptic drugs. When to stop. Suppose the patient is taking the drugs. Should we stop is the question. Now, if there is no seizures for 2 to 3 years, then you can plan. I am telling you, you can plan. You can plan to withdraw the drugs. Now the withdrawal should not be abrupt. Suppose patient comes and tell you, sir, from 3 years I don't have seizures, and you don't tell them tomorrow only stop. No. So you have to gradually taper the dose and then stop. So gradually tapering the dose and stopping may take from 9 to 12 months. It's not going to happen immediately. And many a times when we are doing this process, seizures have recurred. They have come again. So the chances are less, but when you plan, you can plan like this. Remember, anti-epileptics should never be stopped abruptly. Taper the dose if there is seizure-free interval of 2 to 3 years, and you can gradually reduce the dose and then stop it. So this is applications what you need to understand in anti-epileptic drugs. So one of the major topic, anti-epileptic drugs, I hope you understood what is seizure, convulsion, and what is epilepsy. What are the triggering factors for seizures, and unprovoked seizure is called epilepsy. And the targets are sodium channel blocking, then increasing the activity of GABA, decreasing glutamate activity, then blocking T-type of calcium channels, and fourth, opening potassium channel. Please consider the first 5 drugs, that is phenytoin, carbamazepine, valproate, lamotrigine, topiramate, very, very important, and others you just consider on the mechanism of action. Then you have to understand the epilepsy, that is types of seizures and what is the drug of choice for that. And then you have to understand the application of anti-epileptic drugs in pregnancy and when to stop the anti-epileptic drugs. So that is what we had to discuss in this anti-epileptic drugs. Thank you all.